But we're really pleased to be joined this afternoon, by Congressman Paul Tonko. I will introduce the Congressman. He'll speak for a few minutes, and then we'll hear from the rest of our panelists. SHELLY Weissman, who's the Associate Director of the Addiction and Public Policy Initiative, will then moderate a discussion, and then we'll have about 15 minutes for questions from those of you who are participating today. So let me begin by saying a few words about Congressman Tonko. Congressman Tonko represents New York State's 20th Congressional District, which is primarily upstate New York. He has served in this position since 2009 and is on the Energy and Commerce Committee. He's been a real national leader on addiction policy issues and is the prime sponsor of the Mainstreaming Addiction Treatment Act, the MAT Act. So thank you very much for joining us today, Congressman, and I will leave it to you. Thank you.
Hey, Regina, thank you so much, and good afternoon, and thanks to all who are joining us virtually for this very timely briefing on the challenges of dealing with addiction in the time of COVID-19. Before I offer some brief remarks, I would like to thank our host at the O'Neill Institute, and particularly you, Regina, and Shelley, for organizing and moderating today's discussion. And I would also like to thank our panelists for taking the time to inform and enlighten all of us as to what they are seeing in their communities as we deal with these very dueling public health challenges. As a bit of background on myself, I serve as a vice co-chair of the Addiction Treatment and Recovery Caucus, and as you heard from Regina, I'm a member of the House Energy and Commerce Committee, where I've been at the epicenter of congressional efforts to respond to the opioid epidemic over the last several years. During my time working on this issue, Congress has taken some positive steps to address the substance use epidemic with the passage of CARA, with the passage of the 21st Century Cures Act, and most recently the Support Act. With all of these bills moving us in the right direction, Congress has, in my opinion, still not responded with the full measure of boldness that is needed to return, to really turn the tide of the epidemic. Now, COVID-19 threatens to reverse even the minimal progress that we have made in slowing the rates of drug overdose deaths. We know that dislocation and social isolation are key risk factors for substance use. Despite the heroic efforts of those in the treatment and recovery communities during this time, we know that many will become disconnected from support systems that help them stay on that path of recovery. Economic downturns also have a way of exacerbating these diseases of despair. And so the impetus lies on us to set our nation on a path of economic recovery as quickly as possible. Now more than ever, this disease of despair deserves a response rooted in hope. That's why I'm working hard to ensure that the challenges of substance use and mental health are fully addressed in the future COVID response packages that Congress will address. On that front, I'm currently working as a member of a number of initiatives specific to substance use on what I'd like to see included in the CARES 2.0 package that the House hopes to unveil in early May. Let me include amongst those an immediate infusion of $38.5 billion for community mental health and addiction providers to help them keep the doors open and serve patients that are weathering this crisis. A $250 million appropriation in emergency nature for the Substance Abuse Prevention and Treatment Block Grant to help states preserve safety net prevention, treatment, and recovery supports. Inclusion of my Medicaid Reentry Act, which would allow states to restart Medicaid benefits for incarcerated individuals 30 days prior to release to ensure a smoother transition back into their given community. This is particularly important given the outbreak of COVID in many correctional facilities and with many individuals being released back into the community. Eliminating prior authorization requirements in Medicaid on medication-assisted treatments for opioid use disorders. In a social distancing environment especially, this additional paperwork is more burdensome and only serves to deny care. Inclusion of my Mainstreaming Addiction Treatment Act, which would eliminate the redundant and outdated requirement that practitioners apply for a separate waiver through the DEA to prescribe buprenorphine for the treatment of substance use disorder. There is simply no rationale for the existence of this waiver during this time of crisis, when access to safe at-home treatment solutions can mean life or death for millions of Americans. So as you can tell, it's a robust agenda that we're trying to push forward at this given moment. And I'll appreciate hearing from the panelists and the audience on what more we need to be doing. Like many other parts of our society, I think COVID-19 is already posing and will continue to pose a generational challenge when it comes to addressing mental health and substance use. If Congress fails to reconsider the reality of the pain that's out there on these topics and respond appropriately, we will lose any of the progress, that we have made in addressing substance use and mental health challenges. So I'll leave you with a charge to be vocal and demand a response that meets the need. Lives certainly depend on it. So thank you again for inviting me to speak, and I look forward to hearing from you and learning from you and walking together in this journey. But remember, as agents of hope, we're counting on you to be those staunch, outspoken, bold advocates. So go out there and do your thing. Thank you so much. Again, thank you for the opportunity to offer some comments, and just great to be with you, Regina.
Thank you so much, Congressman. That was great, and good to hear all the work that Congress continues to do. And you know, our effort here is to really inform what Congress is doing with the voices of those who are most affected at the local level. So we appreciate all your stalwart leadership.
My pleasure.
So what I want to do is introduce each speaker, beginning with Mayor Williams. Mayor Steve Williams is the mayor of Huntington, West Virginia. He has been mayor of Huntington since 2012. And as everyone on this call know, I'm sure that West Virginia has always been the epicenter of the opioid issues that we face in this country. And he has been a leader nationally through his positions on the National League of Cities, as well as the U.S. Conference of Mayors. So Mayor Williams will speak first. He will then be followed by Dr. Edwin Chapman. Dr. Chapman is an internal and addiction medicine doctor in Washington, D.C. He is board certified in addiction medicine. And he also served last year on the National Academy of Science, Engineering, and Medicine Committee, examining the preventing opioid addiction and infectious disease. So we are pleased to have Dr. Chapman join us. He'll be speaking second, followed by Allie Hunter. Allie Hunter is the Executive Director of the Police Assisted Addiction and Recovery Initiative, or PAARI. PAARI is a Massachusetts-based initiative. She'll be talking about some of the great work that they're doing to, to find non-arrest policy solutions to helping people enter treatment and recovery. So thank you, Allie, for being here. And then last but not least, we'll have Dr. Stephen Loyd. Dr. Loyd is the Chief Medical Officer of Cedar Recovery Services, serving patients in Middle Tennessee. He is also a board certified addiction doctor and previously served in the Tennessee Department of Mental Health and Substance Use. He has also been in recovery since 2004. So we're very pleased to have Stephen Loyd with us as well. So Mayor Williams, if you would begin with your comments, and then we'll hear from the rest of our panelists. Thank you.
Thanks, Regina, and thanks for including us in this conversation. And it's an important conversation. My city became actively involved in 2014 because what we found at the time, what we thought we were facing was a policing challenge. Clearly, when we would try to arrest anybody who would move in the community, and after a 90-day period, we arrested over 200 people. We found that it was one of these situations where you couldn't arrest your way out of the circumstances. And what we found in 2014, that we were woefully unprepared to be able to address the issue, because everything that we had been doing had been law enforcement focused, and we had to get the entire community involved. And the way that we would go about getting the entire community involved was just by beginning to have collaboration, having conversations with all the different entities within the community. And in due time, we started receiving support certainly from the medical community, the hospitals, the health departments, the medical school, the pharmacy school, but we also started getting participation from the business community, as well as the faith community, the neighborhoods, even the elementary schools were getting involved. What we simply said to everyone, if we were going to be addressing the epidemic of addiction, is that everybody had to accept an assignment. Now, as I look back 6 years later, right at 6 years later, we see that our community did accept that challenge. As Regina pointed out earlier, West Virginia has been known, Huntington became known as the epicenter of the opioid epidemic. We obviously took umbrage to that because I got kind of tired of hearing ourselves being announced that way. And what we started realizing is that we, through our partnerships, that we would start creating enough programs where we came to be known as a city of solutions, or the epicenter of solutions, rather than an epicenter of the epidemic. And we've taken great pride in being able to hold on to that. The way that we were able to start making active steps in that direction was by making sure that we had data to support what needed to be done. We didn't do anything based on a political measurement. Let the facts, let the data speak for themselves. And then secondly, creating partnerships, which leads us to where we are right now. During the 6 years, it was not unusual to hear me saying that the epidemic of addiction was the greatest existential threat facing our nation until COVID-19 came along. None of us ever expected this, but the challenge that we're having is that is placing at risk everything that we're doing. But the one thing that I'm finding is that with everything that we structured within our community, again, the hospitals, the health departments, the medical schools, the pharmacy schools, the physical therapy and programs, the business community, the labor community, the neighborhoods, the children, as I said, the faith community, all of those came together to address the epidemic of addiction. But all of that has come together for us to be addressing COVID-19. Two sides of the same coin, totally different issues, but it is also laying bare the gaps that we have in the system. And those gaps have to be addressed, because recovery requires partnership and face-to-face communication. And it's awfully difficult to be able to do that when you are finding yourselves having to be staying alone and sheltering in place when you need to have that interaction. What we've seen is our overdoses started to spike up in March and have settled off and have started to stabilize in April, simply because we are adjusting, utilizing technology and such as that. We look forward to having a further conversation with you through this. This is laying bare those things that where we do have the gaps, but I have absolute faith that we have the ability to find our way on the other side of this. Thanks, Regina.
Thank you very much, Mayor Williams. Dr. Chapman, could you say a few words about what you're experiencing in Washington, D.C.? Thank you.
Yes, I'm so glad to hear the Congressman's remarks because they reflect much of what we looked at the National Academy of Science over the past year. He mentioned prior authorizations as a barrier, also the connection to the criminal justice system, that people should be taken to treatment rather than jail. So there are any of a number of issues, and I would really like to that everyone would take a look at the report at the National Academy of Science. I had the honor of meeting Congressman Elijah Cummings on July 1st of last year to talk about his bill, the CARE Act, the Comprehensive Addictions Resources Act. And then we invited him to a what we called a healing concert on August 16th of last year at New Shiloh Baptist Church in Baltimore, a packed house. And again, Mayor Williams has hit on a key point. You have to have the whole community involved in this recovery process. And it is a disease. But we're still struggling here in Washington, D.C. With that issue. We spiked had an opioid spike in 2017 at 281, which took us per capita to number 3, right behind West Virginia, New Hampshire, and Ohio. So unfortunately, we had another spike in 2019. And our market has been taken over primarily by fentanyl. So in 2015, fentanyl accounted for about 20%. Now fentanyl accounts for 90% of the overdoses. So that is the market that we're dealing with. So we can't afford to have barriers. So this community approach has to take root. The one thing that Congressman Cummings said was that the one thing he hated was research that sat on the shelf. So if we're going to do this research, if we have the data, we have the information, then we need to implement the information. And you obviously have started that in West Virginia. I had the honor of attending a group called One America movement in Martinsburg back in May of 2018, where again, a group of clergy and citizens got together. They saw that there was a very similar relationship between Washington, D.C. and West Virginia in terms of the economics of the opioid epidemic. So we know that when people lose their jobs, they get depressed. And we can see that with this COVID epidemic, that liquor stores were kept open as essential businesses. So we know what that's going to lead to. And we don't have the data on the impact yet of the COVID epidemic on opioids here in DC because we're right in the midst of it right now. Some of our hospitals are full. And I live in Prince George's County, right outside of the city, and was shocked to pick up the paper to find that my county is #1 in COVID deaths. And that is supposed to be one of the most affluent African-American counties in the country. So these combined diseases are devastating. We have put together a community-based approach just in the past couple of weeks, organizing churches, returning citizens, rappers, the hip hop generation to really get the messaging out, because we're concerned that the messaging in our community has to be improved, and it also has to be given by certain trusted individuals in the community. So we're on the same page, and we're with you and glad to see that Congress is services on this.
Thank you, Dr. Chapman. And speaking of the reentry community, I'm going to turn this over to Allie Hunter now with PAARI. Thank you.
Thank you. Thank you for having me on. Again, my name is Allie Hunter. I'm the Executive Director of PAARI, the Police Assisted Addiction and Recovery Initiative. We're based in Massachusetts, and a lot of what I'm going to share today is work that we're doing in Massachusetts. But we are a national organization, actually, with 559 police departments in 34 states. So we were founded in Gloucester, Massachusetts, just about 5 years ago, recognizing that police have a front row seat to the opioid epidemic, and they needed better tools in their toolkit to be able to connect people to resources and services. And as Mayor Williams said, recognizing they can't arrest their way out of this issue. So we mostly work with municipal police, but we do work with a number of sheriff's departments as well. Specifically, we have a few programs where we place recovery coaches in houses of correction to help assist with reentry planning. So about mid-March, we started working, we started hearing from our sheriff's partners that they were canceling some of the in-reach programs that we were part of, the discharge panels, things that would help connect people to treatment and services upon release. And so about March 18th, actually, we started discussing as a leadership team that, you know, folks are being released amid COVID-19. Sheriffs were getting pressure to release people early. Some of the DAs were in support of releasing people early. Actually, in Massachusetts, there was a lawsuit to do so. And so, you know, it was very clear that there would be heightened risk of folks that were being released amid COVID-19, whether it was released early or released because their sentence was over, if they were not connected to appropriate services. The stats vary from place to place, but in Massachusetts, our data shows that people who are released from incarceration are 120 times more likely to fatally overdose than the rest of the population. So, you know, this is a very vulnerable population, both due to COVID-19 and due to opioid addiction. So we started putting together this concept of a survival kit, and, you know, just wanted to share this example of something very practical that we were able to stand up in exactly 1 week, which I think is one of the trends, one of the kind of silver linings that we've seen is that folks are more likely to try new things, to be creative, to be innovative, and to partner in ways that maybe they haven't in the past. So we started putting together this concept of a survival kit, which is something that someone would be given as part of their discharge process. One of the key pieces of that we were leveraging is the changes in teleprescribing. So one key component is that in the packets, there's a hotline, contact information for a hotline through Boston Medical Center. So, you know, someone can call, get assessed, and get a prescription potentially for buprenorphine as part of their discharge process, and they can be assessed over the phone. So this was, again, something new that only would have been possible because of those teleprescribing changes. We also partnered with the Department of Public Health and our local syringe exchange programs to donate the Narcan that went in the kits, as well as information about how to connect to those local services. So we're really trying to connect the dots on local initiatives, local partners, and just kind of give a new tool for people as they're being released from custody to have them have that life-saving Narcan, and then information about how to connect to other services and treatment as well. So basically what we did was we just called the sheriffs directly. The sheriffs that we called said yes, and we launched it a couple days later. So in the kits is Narcan, how to connect to that hotline, how to connect to a PAARI recovery coach, some information about syringe safety amid COVID-19, list of local treatment providers. And now we're in 5 counties in Massachusetts and also helping other departments nationwide replicate this model. Another really important piece of what we have been doing is partnering with Mass Health to decrease insurance gaps. So there's actually new guidance from Mass Health that any individual who is in a Department of Correction or House of Correction with a pretrial status, they actually maintain their community health benefits, which is really important. So yeah, like I said, this is just kind of one example of what we've been able to do in a pretty short span of time to respond to COVID-19 and this really vulnerable population. Like I mentioned, we also work with municipal police departments, and there's been a ton of creativity and innovation with them as well. So would love to get more into that throughout the program. Thank you.
Thanks, Allie. So our next speaker is Dr. Stephen Loyd from Tennessee. If you could tell us about the work that you're doing on the ground with a pretty rural population, thank you.
Sure, thanks, Regina. First of all, I want to thank Congressman Tonko. As you were going over the individual components of the MAD Act, I was getting a lot of hope. Sometimes when I'm on these calls, I'm on the calls with folks from the East Coast. I'm in the rural South. And it's markedly different, some of the things that I face on a daily basis. So thank you. One thing I want to speak to about prior authorizations, in the state of Tennessee, we have a 100% approval rate on them, which is good. But why do you have something in place where there's a 100% approval rate and it's a barrier to treatment? What I'm seeing in Tennessee, and I'm an optimistic guy, and I'm going to remain that way. I'm in recovery myself for almost 16 years from opioid use disorder. So some of these things, anxieties I see in my patients, I fully understand, particularly from early in recovery. But the thing that I'm most optimistic about is, I told Regina in the group this the other day, the genie has been let out of the bottle. Telehealth has changed the ballgame for us. I'm in Nashville. I live in Nashville, but I have a lot of rural areas that I cover with medication-assisted treatment, mainly buprenorphine, as well as methadone. And we've been able to reach these areas, and they've taken a lot of our barriers off the table. I have patients who've been in trouble in the criminal justice system. They don't have a driver's license, and when they do, they run the risk of being reincarcerated. That's off the table. I don't have to have them driving anymore. I've got patients that rely on Medicaid rides to the doctor's office, which are very, very unreliable. That's been taken off the table. I love the connectivity that I've gotten with my patients. I hear this all the time. Well, the computer is not the same as being, face to face, and maybe not. But I can tell you that I'm in my patients' homes. I figured out 3 patients of mine that are homeless that I didn't know otherwise. And now I've been able to hook them up with services to help them in their living situation. And the other thing is I'm in their homes, kind of like you guys. I have a little bit different view of Congressman Tonko. I can see where he is and Regina in her house. And so we've got the same things going on with my patients, projects that they're working on at their houses. They've been able to show me. So I think if we use this in the right way, we can actually build connectivity. I've been, not that I would ever wish COVID-19 on anybody, but the fact that it's opened telehealth up to allow us to use this as a tool to reach our patients, to me, is really a godsend. Now, I want to say one thing about that, is that we don't need to put that genie back in the bottle. So Congressman Tonko, when you're looking at things in policy, we need to have telehealth available even after COVID-19. It's an extremely valuable tool, and I'll use it for what Allie does. We look into prisons and jails, EDs. That's low-hanging fruit for overdose death rates because we know what their risk is leaving the jail, leaving the prison, leaving the ED. Well, now we don't have to have a complicated handoff process. We could set up telehealth and do an evaluation with e-prescribing right from the ED, right from the jail or prison with a warm handoff to a community provider. And so I think this is a really, really big tool. And I'll tell you this, 2 days last week, sorry, I get excited. 2 days last week, I had 100% show rate in my practice. Guys, we're talking addiction medicine. 100% show rate is a unicorn. And I had 2 unicorns in 1 week. So as far as policy gaps, and the thing I didn't see addressed in the MAD Act was the ability to use telehealth going forward. And so Congressman Tonko, I would like to really put that out there. As far as what am I seeing in overdose rates, I'm in Metro Nashville, but obviously rural territories that I cover. It's different each. In Metro Nashville, it's been my experience so far that we've seen a little bit of an uptick. In the rural areas, actually a downturn. One of the things that I didn't realize that my patients have been telling me, it's hard for them to find drugs right now. And that's a really good thing in some ways. And so that could be a little bit of the reason that I'm seeing an uptick in patients coming for our services. And I can tell you, at least for the months of March and April, our practice has greatly expanded. So the other thing I would like for policymakers to look at is getting rid of the 275 waiver. I'm probably right at that right now with all the things that I'm doing, particularly in the homeless community and some other areas around where I'm providing services. And so that hindrance becomes, I get really nervous as I get near that 275 limit. So I really appreciate the opportunity to be on here, and thank you guys for having me.
Thank you so much, everyone. I'm going to now turn it to SHELLY Weissman, who will facilitate some questions. And I think the first one is probably for Congressman Tonko, and then we can go from there.
Great. Thank you so much. And thanks everybody for your comments. And I know Congressman Tonko, you may have to hop off. I'm not sure. So maybe we can start a few moderated questions and start with you. And for folks who are listening in, we do have the chat is not the function to send questions. It's the Q&A function. So, you know, please send in your questions through the Q&A function, and we'll try to get to as many as possible. So, excuse me. Okay. Mayor Williams talked about how COVID-19 is kind of starting to lay bare some of the gaps in our systems. And Congressman Tonko, I know you've been a champion of these issues for many, many years, dating back to your time in the New York State Assembly, championing Timothy's Law, which was either the first or one of the first mental health parity laws in the country. And I'm wondering, what are the gaps that you think and that you see COVID-19 really exposing here, and what can be done to address them? What more can be done? Oh, hold on, let me.
Gaps is,
okay.
I'll reset, Shelley.
Yes.
I think one of the gaps is insurance coverage, making certain that, you know, people have the appropriate insurance. The whole effort for Timothy's Law in New York was to make certain there was on-par coverage. But if there's no coverage at all, that is a really troublesome thing. And so we've seen a number of people threatened with the discontinuation of coverage. There's been a messing with the Affordable Care Act in Washington, which I find regrettable. So I think what we learned here first and foremost is to make certain that all Americans are given the opportunity for access to quality health care. And on par with that package, obviously, is the mental health components and those that deal with substance use. So that is one of the weak spots, I think, that becomes very, 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 very obvious. And then, you know, to Dr. Loyd's point, I think it's very important for us to understand the value of telemedicine, to make certain that there are ways to conduct services now and provide professionalism for those at home, and to make certain that there's that routine contact. So I think we're going to learn a lot about the value of telemedicine that will come from this whole COVID-19 experience, where people have had to adjust and rely on connecting through technology. It's been awkward, it's been challenging, but I think people will find it's going to be a new tool in the toolkit.
Excellent, thank you. And I'm wondering, from Mayor Williams, what else do you think local governments need as they grapple with this dual epidemic, right? We have the epidemic of COVID-19 and the epidemic of addiction and overdose still raging. So what are some of the things that local governments and local communities really need as we start to, as we continue on in this challenge?
Congressman Tonko won't be surprised at this. Rather than the money going to the states, it needs to go straight to the communities. There are those who are of more conservative nature would be saying, well, we need to get money directly to where it needs to be immediately. And frankly, addressing COVID-19 and addressing addiction is on the ground in the cities and in the counties. And frankly, when the money goes to the state and then the governor and others then distribute it on down, depends upon the state, naturally, but more often than not, the money just gets held up within the bureaucracy before it actually gets to where it needs to be. Secondly, depending upon the community, Huntington, West Virginia is just shy of 50,000 people. We're considered big city in West Virginia. But there are small towns throughout rural America, throughout rural West Virginia, that can't even gain access to telehealth. Why? Because they don't even have access to the internet, to broadband. There is a very serious problem that we have to be able to address to make sure that broadband connectivity is available all across the country. I have one person who's listening in on this call is the Associate Director of the Division of Addiction Sciences at Marshall University, and she's telling a story about a peer navigator down in the very rural part of West Virginia ended up dying from overdose just because she wasn't able to connect. We continue to hear the opposite of addiction is connection. Well, if you can't connect, how are you able to help? And what we're finding is that in our innovation, I guess it basically comes down to this, is that cities are the laboratories of innovation, then small cities, small towns are the petri dish. And we can identify sooner what works, faster what doesn't, and quicker how to fix it than necessarily going to the largest of the cities across the country. So the first and foremost, Congressman Tonko, we thank you for everything that you're doing. And we do believe that when this next incarnation of funding that comes in can go directly to cities and to counties to be able to address, but it can't just be COVID-19. We have to continue to fight the fight against addiction.
Shelly? Shelly, if I could respond, I don't know.
I can hear you, Congressman.
Oh, you can? Okay. I just wanted to respond to the mayor because he raised some very good points. And as many on the line on this Zoom broadcast are probably aware, there was an effort beyond belief to get aid to local governments and cities and counties to go directly from Washington to that source, as the mayor suggests. Everything was tried. Every argument was waged. We're going to continue to fight that. So fight for that opportunity. And hopefully in iteration 4, which will probably come in the form of CARES 2.0, CARE 2.0 will hopefully have that kind of aid. I don't understand the unwillingness to not assist our local governments. And there are a number of issues out there, public health included, that need to be addressed. I would also caution when you talk about some of the concerns and the gaps, if we continue to look at Medicaid cuts as is suggested and programmed, there are those that are onto that effort. I would strongly advise that we get outspoken as an advocacy group. There's no bigger payment mechanism than Medicaid for mental health and substance use disorders. So we have got to maintain that funding at current levels, if not expanded.
Great, thank you. I'm going to ask a few more questions and then I think we'll get into Q&A from the audience. So Dr. Chapman, you mentioned Prince George's County and this, the really high rate of death of people who are African-American from COVID-19. And we know that data is emerging that shows a trend of this across the country. And it's really reflecting long-standing racial disparities in access to healthcare, particularly access to mental health and addiction treatment. Do you think COVID-19 is exacerbating these disparities with respect to substance use disorder, and what can be done about that?
Yes, absolutely. I think potentially it could be a barrier. COVID-19 also has been a wake-up call. And as the congressman pointed out, we now see that everybody needs health insurance. I've been at 275 opioid patients for 3 years. And these patients are the most compliant. We're able to now get them into mental health services. Washington, D.C., of course, had an older population of, that started 60 years ago, post-Vietnam, with heroin. And by the time I was seeing the patients, 60% were testing positive for hepatitis C, 10% for HIV. So now 80% of my hepatitis C patients have been treated through a connection with Howard University's infectious disease program. We're able to stabilize patients and keep them on their HIV medicine. The other thing we need to really note that when a parent dies or when a caretaker dies, that we've seen an uptick in the foster care system. So I read an article about Cecil County, Maryland, and a police officer actually discovered going to the school system that 30% of the children were in foster care because their parents or caregivers had died when the automobile plant closed across the river in Delaware. So all of these connections, I tell folks that opioid addiction is not just one disease, it's about 6 different diseases, but we can actually save money by keeping people in treatment. My longest retained patient is 15 years. I got him when he was 58, multiple years in prison. He's never been back to prison, never been back to the hospital. Did a TV show with him in New York at CBS. So these patients now go back to the community and their teachers. There are linked to history. We have to, in the African American community, have to re-engineer our thinking because so much damage was done using incarceration as treatment. Incarceration is not going to solve the problem. It's really going to exacerbate the problem. Worst place to put someone addicted to drugs is in jail because you have the highest rate of infectious diseases in the criminal justice system.
Thank you. So I'm going to start incorporating audience questions. So the first kind of set is geared towards Dr. Loyd, but of course, folks, please feel free to jump in and answer. And, you know, Congressman Tonko, Mayor Williams, and Dr. Chapman, everyone's been talking about Medicaid and access to insurance. Obviously, Tennessee is one of the states that has not expanded Medicaid. So, you know, if you could speak a little bit about what are strategies to ensure people can still get access to services or to get, for providers to get reimbursed for services in this situation, as well as what the harm reduction landscape looks like in Tennessee right now. We got some questions related to syringe services programs and access to medications for opioid use disorder as well.
All right. Oh, thanks, Shelley, and I appreciate the question. Not being a Medicaid expansion state hurts us. I mean, that's obvious, exactly what Congressman Tonko said, and as well as Mayor Williams and Dr. Chapman is, you know, everybody needs insurance, and that is not the case here. Now, I'm a bit of a skewed population to ask that question because of my prior work with the Tennessee Department of Mental Health and Substance Abuse Services. Because as a result of that work and some of the programs that I know became available, I'm able to get care for my patients through block grant money coming down through the department. So our practice is for the most part, about probably almost 90% Medicaid, and the other 10% is the safety net money that comes through a federal Medicaid program into the state of Tennessee. What I see and where it really hurts us is that a lot of our patients go to cash-only clinics. And I've talked about this with Regina a ton. And so you have these cash-only clinics that are raising stigma for the treatment of people with opioid use disorder, which hurts us all the way around, mainly with law enforcement. because law enforcement sees cash-only clinics, and they see the clinics, you know, the pain clinics of South Florida, and then really all across the country a few years after that. And they see some of the same providers that are providing services in there. So that raises the stigma. It makes them less likely to be able to want to work with us whenever it comes to MAT. And so I guess that's the big place that I see where it really hurts us. We have a lot of our patients in Tennessee who actually have Medicaid, who have TennCare, which is our Medicaid here in Tennessee, that wind up going to cash-only clinics because they don't have a Medicaid provider in their area, which hurts us as well because they actually have the benefits, are not utilizing it, and now they're spending money that could be used for other things, you know, in order to get addiction treatment. So I'd really like to advocate for us becoming a Medicaid expansion state. I don't know how to, you know, how to get that changed for the time being. But through working with other community partners, exactly like Mayor Williams said, working with other community partners, we've been able to get people, at least in the practices that I work at, we've been able to get people access to treatment through those programs. The problem is knowing those programs exist and then being able to connect people with them.
Great, thank you. We're getting some questions about collaboration with the faith community. Mayor Williams, you spoke about it, as well as you, Dr. Chapman. And I'm wondering if folks can talk a little bit more about what are things that can be done to strengthen those relationships? And is that a way to reach people that maybe are in areas that might not have broadband access or access to technology? Maybe we'll start with Mayor Williams and then go to others.
Yeah, Shelley, thanks for this question. And I hear this question quite a bit in most of my conversations around the country. We, at the very beginning, had the faith community involved. It was interesting. I was having a conversation with some pastors about the concern of addiction, and that how we needed to be able to reach out to individuals, and that there's certain stigma that is associated with this. And there was one pastor that said something that was insightful, and it wasn't intended to be negative, but it was quite insightful. He said, if we're going to do this, prepare to be inconvenienced, because we're going to see different types of individuals sitting in our pews that we have not been used to seeing. What I'm most proud to be able to see is that in everything that we have been doing in addressing the epidemic of addiction in our community, the faith community has been actively involved. I had one pastor that said, somebody came up to me and said, I'm fighting addiction, I don't know what to do. And he said, I don't know what to say. All I can do is hug them and say, I'll pray for you. He said, I need to know more of what I can do. And the faith community came, and this wasn't just Christian churches, and it was the entire faith community, Muslim, Protestant, Catholic, Jewish, other faiths, all actively involved, where they went through a several-week training period as to how to prepare themselves and help prepare lay people within the community. I could go on and on with this, but the most significant aspect was we created a quick response team several months ago, a little over a year ago, and it had an immediate effect on our community being able to address overdoses and to reduce the overdoses. Our overdoses were down over 20% year over year just last year. They're about flat right now, but our quick response team involves a police officer, an EMT worker, a recovery coach, and a pastor. As I understand, we might be the only community in the nation that has involved the clergy. And the clergy came and said, we don't want to just try to offer some support on the side. We want to go along with you. It doesn't necessarily mean that they're pressing and pushing religion down someone's throat. If there's somebody that lets it know, I don't want any of this religious appropriate or sometimes inappropriate descriptions, the pastors are there for the QRT, the other QRT people. And it's proven to be just an absolute, no pun intended, a godsend for us.
Shelley, I'd like to address that if I could as well. when I was still with the department several years ago, we did a ton of legwork in this area. And we actually have within our Department of Mental Health and Substance Use Services a wing of that focuses just on this. About 2/3 of the people in the state of Tennessee identify with a faith of some sort, 2/3. So we realized it was the biggest untapped resource we had in our state. The other thing is it's cheap. So it meets that criteria. And so what we started doing is we started certifying our congregations in recovery. Yeah. So it took a lot of legwork. We had 95 counties in the state of Tennessee, and a lot of them rural. I've been in more church basements than I can shake a stick at. But what we would do, we would go and educate these congregations on recovery. Exactly what Mayor Williams has said. There's going to be some different people show up, and then how are you going to adjust to that? Maybe they don't drive the car that you drive or wear the clothes that you wear, but they are people in need. And it was really an amazing experience for me. When I was the assistant commissioner, it was the one program that I got the most calls about from other states. And so we actually formalized it within the state of Tennessee. It continues to go to this day. It's run by Dr. Monty Birch, who does a great job with it. But the opposite of addiction is not recovery. The opposite of addiction is community and relationship. And the faith-based congregations are a great tool to utilize, and it fits very nicely with their mission.
I would agree totally. I've given talks in at least 10 or 20 churches. The faith community is the key. I got invited to Shreveport, Louisiana last year during Black History Month to speak at a church there. And the church was full. And once you educate on the disease of addiction, how it impacts the brain, I showed PET scans of the brain. It was amazing. And the feedback, once you educate the faith community, the stigma disappears. So we gave healing concerts, at least 4 healing concerts, and then the city actually paid for a faith-based education program in August of last year here in Washington, and about 22 churches participated in that. They then are poised to do other things, food banks, clothing banks. These are the most amazing patients I've ever had.
Shelly, I see a question on the Q&A. Someone asked, how do we connect with the Islamic communities and support them in this regard? The training that I indicated earlier that the faith community put together, one of the leaders of it was the imam of the local Islamic congregation. I was invited a couple of times. I'm a Christian, and I was invited a couple of times to Friday prayers, and it was such a wonderful experience to talk about what we were doing to address the problem of addiction in the community. And I'm really pleased to see that the Islamic community is a very, very active participant in this effort.
Shelly, we've had that in Tennessee as well. You know, the Islamic community, the Jewish community, it really gave me a lot of hope as I got involved in this, because I agree with Dr. Chapman. Once people understand addiction, it's amazing what they'll open their minds to. You know, donating church buses or vehicles to take people to and from doctor's appointments that maybe had lost. I mean, there's so many things that they can do. But to what Mayor Williams was saying, it didn't matter what your religious background was. And it's like people just kind of checked that at the door and said, you know, here's this group of people that we're all trying to reach. How can we work together to reach them? And it was really uplifting for me to see.
Great. Sounds like one, hugely as yet untapped resource. Want to shift gears for kind of the last set of questions to some questions we're getting about the workforce and supporting the workforce. And that includes first responders, as well as folks that might be administering naloxone, folks that are working in programs. And we have kind of a series of questions related to support for the mental health of the workforce in this time, as well as personal protective equipment and other kind of training and support. So I wanted to kick it to Allie first for that question, and then others would be great to hear you weigh in, including Congressman Tonko.
Sure, thank you. So I know it's a complex question with many aspects, so I'll kind of maybe just touch on the things that PAARI is working on. We continue to provide kind of resources to our law enforcement partners as they adjust to their programming and make sure that they can maintain their safety as they're interacting with this population and continuing their outreach services. So a lot of what we try to do is listen to those on the field and pick up what their innovations are, their strategies are, and then share those more broadly. So for example, many departments, instead of doing follow-up visits at people's homes, they're calling them first and seeing if they can leave something on their porch. Many departments are mailing people Narcan or dropping it off on people's cars or things like that. So we try to pick out what are these changes, these adjustments, and how do we share them with others, because our law enforcement partners are still incredibly dedicated to doing this work and keeping this population at the front of their minds. So we've been trying to, like I said, kind of advise them as best we can based on what we're seeing others do, and how to use technology, how to use, different resources like that. We are also piloting a program right now where departments are distributing fentanyl test strips and seeing how those work as an engagement tool. So that's been kind of interesting, even though different than we originally intended because of COVID-19. It's been cool to have kind of a learning community of 11 departments that are all trying something new together. And there's just been an incredible openness to trying things that are new. I did see a question about maybe reluctance to administer Narcan, and that hasn't been my experience at all. I actually did share the article that I think was referenced there, and our law enforcement partners were kind of like appropriately disturbed by that. So I think that, my experience is that law enforcement are still continuing to provide those life-saving services and taking precautions for their personal safety as well. There certainly have been adjustments that I'm sure have created hardship. I know a lot of departments their shifts are different. Some departments are doing 24-hour shifts, and of course that's going to take a toll. So I think that they're trying to be as innovative and flexible as possible, but it certainly has been, I think, difficult and more draining than usual.
Mayor Williams?
Yeah, Shelley, our city received a $1 million Bloomberg Mayor's Challenge grant a couple of years ago. We put together a program to address compassion fatigue among our first responders. The idea is very simply this, is that we have to be able to help those who are trying to help us, help the helpers. Where it came out to us is that we started hearing concerns among our first responders and the police officers and our firefighters that said, and this was a bit of a jolt to us, said, oh, you're more concerned about those who are addicted than you are of us. And we started to realize that they were experiencing post-traumatic stress as well. And what we've done is we put together a series of programs to offer wellness programs geared directly to first responders, police officers, and firefighters. Certainly, what we started seeing is that they were responding to so many overdoses, and so many of the individuals who they were responding to were individuals whom they may have grown up with, and where they were seeing that people who died were people who they were in school with. And it was just eating away at them. This one man, once we came out with the program and a member of the press asked him, so what would you be doing if the city hadn't developed this? And he said, I would be drinking myself to death. Now, as a result of this, we had the $1 million. The beauty of it is that with Bloomberg, they require us to come in and actually do an awful lot of testing and measuring to make sure that we are accomplishing what we want to accomplish. And the advantage is that this is something that will be able to be replicated elsewhere around the country to other communities for their first responders, but it can also be replicated to emergency room workers, to clergy, to teachers, and on like that. We, aside from the $1 million grant, actively fundraising $650,000 to build a wellness center for our first responders. If something happens, we had a death of a family that died in a fire just last week. As a result of this, we have a behavioral health person who is able to come and meet with the firefighters immediately the day of, and be able to provide that support. So you have to be able to provide that. And then lastly, related to Narcan, as I've talked to other communities that have been reluctant to give first responders Narcan or naloxone, remember, we're dealing now with fentanyl. And fentanyl, once it becomes airborne, can start to strike a first responder. And we've had 4 different police officers that have been exposed to the fentanyl. And if we had not placed naloxone with them, who knows what would have actually happened to them. So if we're going to provide naloxone to provide protection to our first responders, we also then have a legal responsibility that if we are out helping someone and we have naloxone to be able to save ourselves, then we have to be able to provide that, administer that to the person who needs it. If nothing else, if you can't justify it for any other reason, justify it that you're trying to protect your first responders.
Thank you. So I think we have come to the hour. I wanted to give time for folks to just give, 1 minute closing thought. And we got a lot of great questions that we didn't get to, and suggestions. People asked about mobile methadone. People asked about relieving the cap on prescribing buprenorphine. As Dr. Chapman mentioned, people asked about increasing access to harm reduction services and syringe services, as well as recovery supports. So a lot of great questions and great ideas out there. So I'm gonna kind of call on folks, if that's okay, to give closing remarks and then turn it back over to Regina. How about we start with Congressman Tonko? Oh, I'm
Yes.
sorry, 1 moment. Yeah, okay, got it.
Thanks, Shelley. Just quickly, I think what we've learned here is that there is still an epidemic that needs to be addressed with within the addiction arena, and that means we can't lose a beat here. We need to go forward aggressively and with a determined voice to make certain that we fund these programs, that we get the dollars to the program people that can administer the services, and also understanding from COVID-19 that there is this disparity in terms of now looking at the profile, the demographic profile of who's been impacted by this virus most severely. And it tells us that public health in America has great adjustment to do when it comes to people of color, people of brown, black, that are part of the overall populace of America. We need to have a fairer approach. We need to make certain that we understand these public health policy disparities cannot continue, and that we need to make certain that we address both of those concerns at the same time. So, and to do the workforce development, because we're going to need the service providers that are required to get this done. So a need to grow that workforce and to have a conscious awareness of the demographic profile of COVID-19.
Great.
Thank you for the opportunity today.
Thank you very much. Dr. Loyd, any closing thoughts?
I love what we've talked about here today, but I think going forward that, the message still has to be consistent that addiction is not a moral failure. And that's really the thing that I run into most often in my day. I look at how I'm treated as a physician in recovery, yet the person next to me who may not be a doctor who's in recovery is not treated the same way. And so as I tell folks, I'm for anything that removes a barrier to helping someone have a chance at long-term recovery. And so that starts with stigma. So remember that this can happen to anybody. It doesn't know any bounds. and that we need to continue to meet people where they are no matter what and help provide a path to recovery that's right for them, not what's on our internal belief system.
Excellent, thank you. Allie Hunter?
Yeah, thank you. I mean, I guess what I want to end with is just that this is a unique moment. This is like an opportunity to try new things and to be creative, and things that have been obstacles in the past are things that, you know, people are willing to be more flexible, more creative, more willing to act quickly. Something that you might have needed a year to plan, you could stand up in, you know, a few days or a few weeks. So I encourage you to think about those opportunities. There's, as we've heard, there's still a lot out there for people, like with telemedicine and virtual recovery supports. There still is, I think, hope in this, even though overdoses are on the rise in some places. And then lastly, I would just say, for all the people that are providers and caregivers and first responders, don't forget to take care of yourself.
Thank you. Dr. Chapman, final thoughts?
I'm going to say love. When we see the first responders, the bus drivers, all of the people that go to work every day, put their lives on the line. And I don't think I could say it any better than Martin Luther King said in his letter from the Birmingham jail. We're caught in an inescapable network of mutuality, tied in a single garment of destiny. What affects one directly affects all indirectly. So this COVID and the opioid epidemic really tie this together.
Thank you. Mayor Williams?
Just three very quick things. First of all, every one of us on this call in this meeting has an obligation to lead. Every one of us has an obligation to lead. If you don't take anything else away from this, you have to step forward. And COVID-19 and the epidemic of addiction all come together because they are both sides of the same coin. If we don't have the data and we can't measure it, then you have to consider it's not happening. Data creates a measurement that gives us the ability to create partnerships. We are collaborating, creating partnerships that establishes trust, and then the outcome is hope. Lead, get the data, and create partnerships.
Excellent. Thank you all so much. I'll turn it back over to Regina.
Thank you very much for each one of you, for your voices, for all the work that you do to make a difference in your communities, for everyone on the call. We will follow up. We had many unanswered questions. We'll seek to answer those. And we'll post it, we'll tweet them out, we'll use social media to get information out. But again, this is the beginning of a conversation, not the end. We have a lot more work to do. Thank you so much for everything you do.
Thank you all.
Thank you.